Hello, dear friend. Let us have an introduction about what is going to happen in this video. Actually, I am a NEET PG aspirant. Okay, don't compare this video with any teachers' classes that we are attending to because I am one among you only. Okay, I am a NEET PG aspirant. What we are going to do is we are going to have a quick look on first aid. First aid is a book that is being recommended by all our seniors, all our teachers, and they tell us that this is a very high kind of a book which is packed with information, right? But when you try to read first aid, we understand that it is a bit difficult because it needs concept. Okay, we need to understand everything is written in the shortest way possible so that it is very easy to revise it in the end. So in order to make this journey easy, or in order to have somebody with me to study, it would be glad for me to know that somebody else is studying with me. That is the reason why I'm starting this YouTube channel. So as I said, this channel is with due respect to all my teachers. So let's study together. First of all, you need to look at the page number. So the first thing that we are going to start with is Endocrine Pathology. This one is 344 page. And we are going to start this syndrome of inappropriate ADH secretion under endocrine pathology. Okay, so this is what I am going to study today. Okay, so and also I am using USMLE First Aid Step 1 2022 edition, the recent one. Okay, so let's start with SIADH. Okay, first of all, hypothalamus is going to secrete ADH. Okay, what is ADH? ADH is antidiuretic hormone which is going to get stored in the posterior pituitary. Okay, we also know another hormone that is getting stored in the posterior pituitary in the similar manner, secreted from the hypothalamus, secreted along with ADH, getting stored in the posterior pituitary. What is that? That is oxytocin. Okay, ADH is antidiuretic hormone, also known as vasopressin. The other hormone, this twin brother, is oxytocin. Okay, so what is this ADH going to do? We now know that ADH is antidiuretic hormone. So clearly it is going to prevent diuresis. Okay, it prevents diuresis. It prevents water from going out. It prevents water from going out. How? By acting upon the medullary collecting ducts, aquaporin channels. There are many aquaporin channels in the medullary collecting duct. It is going to act on that and it prevents water from going out. Okay, so with this basic idea, we are going to come on it. We are going to come back to this figure again, and with this basic idea, we are going to go to the explanation. Okay. So, SIDH is characterized by excessive free water retention. Okay, excessive free water retention. Why? We have got an antidiuretic hormone in action. Antidiuretic hormone is going to prevent diuresis. It is going to prevent water from going out, and therefore there will be excessive free water retention. Don't read this now. So there is excessive free water retention. Up to here it is clear. So if there is excessive free water retention, is the body going to sit silent? No. Body needs homeostasis all the time, and therefore body is going to respond to this water retention by decreasing the aldosterone, increasing ANP, BNP. So let us check on who are these people: aldosterone, ANP, BNP. Okay. Aldosterone, we know it is part of the renin-angiotensin aldosterone pathway. RAS pathway. Okay, what is that going to do? It is going to decrease the sodium. It is going to cause sodium water retention. So decreased aldosterone is going to have the opposite effect of increased sodium and water retention. No? So it is almost like it is going to cause diuresis. It is going to cause excretion of sodium and water. It is since there is decreased aldosterone, there is decreased retention of sodium and water. So it is almost like water going outside. So what is ANP and what is BNP? ANP is atrial natriuretic peptide. BNP is brain natriuretic peptide. ANP is a good boy. Why? Because atrial natriuretic peptide means it is correctly named. Why? It is secreted from the atrial myocytes only. Brain natriuretic peptide, we would think that it is secreted from the brain, but no, it is secreted from the ventricular myocytes. Both of them are twin brothers. Their physiological actions are going to be similar. Okay, so ANP is increased and BNP is also increased. ANP, actually what is it going to sense? We know that water is getting retained in our body because of the action of this antidiuretic hormone, no? So when there is increased volume inside the blood vessel, ANP is going to detect that volume. BNP is going to detect that stretch or that tension. So that force is getting detected by the BNP. That is the only difference. Otherwise the physiological action is similar, and BNP is going to have a longer duration of action, longer half-life than ANP. That is the only difference. So ANP, what is the action of ANP? ANP causes loss of water and salt in urine. If the salt is getting secreted in urine sodium is going to go to more than 20 milliequivalents per liter. Urine sodium in SIADH is going to be more than 20 milliequivalents per liter. Therefore, in response to this excessive free water retention, what happened is this ANP and BNP started acting, and it caused loss of water and salt in urine, causing a urine sodium more than 20 milliequivalents per liter. Therefore, there is increased sodium secretion, and there is water also getting secreted now. So there is normalization at the extracellular fluid volume, yes, and there is euvolemic hyponatremia. What was happening in the initial phase? We had excessive free water. So water getting secreted out caused euvolemia. Now the water is corrected. Okay, but ANP and BNP, they are causing continuously sodium is getting excreted. Therefore there is euvolemic hyponatremia. So how are we going to treat this thing? Okay, so before coming to the treatment, let us go into some other part of the story. So what is the criteria for the diagnosis? This criteria for diagnosis is called as Bartter-Schwartz criteria. Okay, what are the components of Bartter-Schwartz criteria? Please excuse my handwriting. We need to annotate first aid. So there will be decreased serum osmolality. Will there be decreased serum osmolality? Do you think so? Sodium is getting excreted out now. So there is decreased serum osmolality, and it is going to be less than 275 milliosmol per kilogram. Okay. Then urine osmolality has become more than serum osmolality. Right? What about the urine osmolality? How much is that? Urine osmolality has become more than 100 milliosmol per kilogram. Okay, why it is kilogram? Because it is osmolality that we are dealing with. Okay, so urine osmolality has become more than the serum osmolality. Urine osmolality being more than 100 milliosmol per kilogram. We know that, right? Serum osmolality has decreased because lot of sodium is going out. There is hyponatremia. Urine osmolality is more than the serum osmolality. This has won the race because lot of sodium going out. Urine is rich in sodium. Osmolality has increased because there is increased solute. Urine osmolality is more than 100. Euvolemia clinically. But when we check the patient clinically, the patient is euvolemic. Okay, there is no hypovolemia. There is no tachycardia, no symptoms like that. The patient is euvolemic clinically. Why? Because rightly our homeostatic mechanisms like ANP, BNP, aldosterone decrease, everything has acted and made the patient euvolemic. And what about the urine sodium concentration? Increased urine sodium. When you take some urine of an SIADH patient and you calculate the amount of sodium in it, it is going to be more than 20. Then, and also I actually forgot the value. So 20 milliequivalents per liter. Okay, it is more than 20 milliequivalents per liter. And there are also absence of other causes. That is another criteria. There shouldn't be any other cause that claims that is the reason why this body is going to have hyponatremia. So absence of other causes like pituitary, renal, adrenal, thyroid and liver diseases. No other diseases like that. Okay, so these are the 5 criteria for the diagnosis of SIADH, Bartter-Schwartz criteria. Okay. Now let us check it, the treatment. Okay, what is the treatment of SIADH? SIADH, the treatment is fluid restriction. Why? Because ADH is causing sodium and water reabsorption or retention. So there is lot of fluid. ADH is actually trying to keep lot of fluid inside our body. So we don't need excess of fluid from the diet. So or through IV line. So we are restricting the fluid of this person. Okay, one thing, that is the first line. Do you think the person is going to, or the patient is going to abide by what we are telling? Don't drink much amount of fluid. No, because it is not going to happen. It is actually they are going to drink somehow. They are not going to restrict their water. So I have heard teachers telling that fluid restriction is difficult to abide by, so it is better to give this drugs like ADH antagonists. We are going to come to it. So first line, we are going to tell the patient to restrict the fluid, that is the first line. And next is salt tablet. Salt tablet means we know that sodium is low in our body, so if you give salt tablets NaCl, it is going to increase the sodium. Just common sense. Then IV hypertonic saline. We know that normal saline is 0.9%. Hypertonic saline has got lots of NaCl in it. Then IV hypertonic saline, that also fits. Diuretics. Why? Antidiuretic hormone is in action. Antidiuretic hormone is excess. So we are going to counteract that action of antidiuretic hormone. So we are going to give them diuretics. Okay. What about ADH antagonist? That also fits in now. ADH is excess. ADH antagonist is going to be a very useful thing. What are the ADH antagonists that we have? Conivaptan, tolvaptan, democlocycline are the 3 ADH antagonists that we have. So the ADH antagonists are also going to work well with SIADH. What are the causes of SIADH? Okay. I'm having problem with this reflection. So SIADH, what are the causes? The causes include held up water. That is a mnemonic that they have given. Now we know that there are loads of water inside our body. So that is called as held up water. What are the reason? H is head trauma or CNS disorder is one cause. Then E for ectopic ADH. What is that ectopic ADH? Where was ADH? Who secreted ADH? We know that hypothalamus secretes ADH. Okay, hypothalamus was secreting ADH. If there is some other person who is secreting ADH, it is going to ADH is going to be high in our body. So who is going to secrete this ADH ectopically? Small cell carcinoma of the lung, odd cell carcinoma of the lung is an ectopic ADH secretion source. There are many sources. Actually, this is a very concise thing. Then exogenous hormones like vasopressin, desmopressin, oxytocin. Okay, these are other causes of SIADH. Lung disease like asthma, pneumothorax, positive pressure ventilation. Do you know why I actually clinically I annotated this with this asthma, pneumothorax, PPV? Because this is a recent NEET question. Okay, they asked in which of the following cases SIADH is not going to occur, and the answer was primary pulmonary emphysema. The options were odd cell carcinoma of the lungs, tick. Okay, their SIADH is going to occur, right? Okay, asthma, when they give the option as asthma, it is going to have SIADH. Pneumothorax also has SIADH. Positive pressure ventilation, these people are also going to have SIADH. But primary pulmonary emphysema is not a condition where SIADH is going to occur. Then some other drugs are going to cause SIADH. We need to remember these drugs. SSRIs, very common drug given in psychiatry, carbamazepine and cyclophosphamide. These are the drugs, some of the drugs only. There are lots of other drugs that are going to cause SIADH. So some of the drugs are SSRIs, carbamazepine, cyclophosphamide. Okay. Then some other causes are acute porphyria attack and multiple sclerosis also. I think they had been asked in the exam. That is why I noted it. Okay. And then there is another thing, confusing thing called as SIADH and cerebral salt wasting. Both of them has got something in common. Both of them has got hyponatremia. What is the difference between SIADH and cerebral salt wasting? What is actually the cerebral salt wasting? Now we know, we are familiar with this SIADH. Now what is cerebral salt wasting? In cerebral salt wasting, there is hypersecretion of ANP. Who was ANP? ANP was our savior. He acted and reduced the amount of water in our body. So there is hypersecretion of ANP in cerebral salt wasting. So even though both of them have got hyponatremia, the cerebral salt wasting, it is going to have hypersecretion of ANP, and therefore there will be polyuria occurring. But in SIADH, the urine output is going to be normal or decreased. But in cerebral salt wasting, there is hypersecretion of ANP. So that concludes our ANP chapter, SIADH chapter. So let us check this one again. Hypothalamus secretes ADH along with what? Along with oxytocin. Oxytocin, vasopressin coming together, getting stored in the posterior pituitary. So that is a place where they store these two hormones, and this ADH coming out this ADH, this positive mark going to SIADH, so ADH is increased in SIADH. ADH goes and acts on the medullary collecting duct, aquaporin channel, okay, prevents the water from going out, okay. So what will happen here? There is increased urine osmolality and decreased urine volume. Why? It is causing antidiuresis. So there is decreased urine volume and increased urine osmolality. Why increased urine osmolality? If diuresis is getting prevented, then the solutes are getting concentrated inside the urine. No? So there is increased urine osmolality. Then what else? Central diabetes insipidus, that we will learn in the next topic only. Okay, so that is it. Thank you.